Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We are so happy that you chose to spend some time with us, and we will jump right into our discussion for today, led by our founder, Dr. Randall Maxey.
Thank you very much, Dr. Barbara Stevens. Good morning, everyone. Thanks for joining us on this beautiful Sunday afternoon. Our topic today, we've talked about a lot about heart disease, its connection to kidney disease, and hypertension, and all the things that make our longevity in jeopardy. So, what we want to do today is go through a list of common questions that people may have, but I want to keep the floor open so people can ask myself and the moderators questions they may have if we haven't covered all the questions that we think you could possibly answer. So with that, let's go to anybody else on that neighborhood? Other co-moderators?
Yes,
Dr.
Dr.
Hines
Walks?
and
Hello,
Dr.
Dr.
Hines are both on.
You
And
took the
Dr.
words right out of my mouth.
Okay, good, very good. So everybody has a list of questions. We're gonna go through them, and we'll discuss them. You can agree or disagree with the answers that I put, and we can discuss them. Let's put the slides up. Put the question up, Simon. And Dr. Neighbor, can you start off asking the first question you see?
Okay. Why are kidney disease, high blood pressure, and heart disease discussed together?
Okay. So, from my standpoint, they're discussed together is because they're connected. High blood pressure affects your kidneys, the glomerulus, it affects the heart, and it also affects every other organ in your body. What do you think, Dr. Neighbor Stevens?
Well, it's a old metaphor, but the body is a well-oiled machine, all integrated in all parts. The head should not be separated from the rest of the body. And yes, those are some integral engine parts, and
So,
they need to be discussed together.
so the ankle bone is connected to the toe bone, right?
Correct. And
Dr.
you'll miss that toe if it has to be amputated too.
That's true. That's true. Dr. Walsh, got any thoughts on that?
Yeah, Dr. Maxey. First of all, yes, I do agree with your answer. I think that was one of the things you wanted us to say. I do agree with your answer. And I think one of the reasons that they should be discussed together is because they're all things that you don't know are going wrong, falling apart, stopping working until bad things are happening. They don't give you early warning signs.
Okay. And what about your boss, Dr. Hines?
So I would say it's wonderful. I agree. And it's wonderful to discuss them together because I think for most of us without medical training, we think of kidneys and their role with urine, right? So it is not intuitive that your kidneys are linked to, and your kidney health is linked to your blood pressure and subsequently heart disease.
Thank you, Dr. Hines. Dr. Walsh, want to take the next question?
The next question, can I have kidney disease and feel completely normal? Okay, that's question number two.
Go ahead and comment.
Okay, well, Dr. Maxey, your answer is yes. Early kidney disease often has no symptoms. Many people do not know they have kidney disease until blood or urine testing shows a problem. I think that may be true almost all the time, but watch me now trying to comment on what the expert kidney doctor said. I I think that people may have subtle things going on. People may be urinating a little bit more than normal. They may see some additional bubbles or foam in the urine, and people tend to ignore that. So I don't know about completely normal, but I think that when things are starting to go wrong, yes, you probably won't notice anything.
Yeah, and we know that high blood pressure is the silent killer. So we don't know when things really start. So it's very important to make sure your provider or your physician or nurse practitioner does the right test on you so you know what's happening. Dr. Hines, do you want to comment on that?
Yeah, I was going to say that all three of these have that in common, right? So, as you just pointed out, high blood pressure is the silent killer. So, most people feel just fine as their blood pressure is creeping up. You're not usually getting a headache when you're in stage 1 hypertension, right? But it's still hypertension. And the same thing with heart disease. The majority of people don't realize they have heart disease until it's bad enough that it is changing something. It's changing my stamina. It's changing, hey, I used to be able to do 9 holes. Now I'm exhausted after 6. So they all have that in common.
Any thoughts, Dr. Neighbor?
No, I think that it's been well commented on in terms of, except that I would just push it a little further than Dr. Walk said, that we need to be in tune and listen to our bodies and not be so busy or not so distracted that we don't pay attention even to those subtle signs.
Very good. Dr. Hines takes the next one.
Sure. What kidney numbers should I know? And the answer that Dr. Maxey put forth was that we should know our eGFR, and that's going to usually be present on those blood panel results that you get with your doctor pretty routinely, and that is going to estimate how well your kidney function, how your kidney filtering function is working. And then your urine ACR, which is a check for protein leakage in the urine. So these two numbers can help identify kidney disease and estimate future risk. I completely agree with that response. I would say the eGFR is happening pretty frequently. The urine ACR, sometimes you might have to remind your provider, humans that they are, right? If you know you have risk factors or that you're concerned, hey, have we checked my urine for protein? And that's why we have the Black Health Trust, so that folks can be aware of things that they can advocate for themselves.
Yeah, and Dr. Walks mentioned earlier, sometimes you might see foam or bubbles in your urine, and that means you probably have protein, probably, and you want to have that ACR check. And I think it may come normally when you do your urinalysis. I know they'll say if you have protein, but
it does. But I would say that BNP is happening, or that BNP or CNP is happening pretty often. The urine, outside of a few scenarios, usually is because you're looking for something. But that BNP is happening all over the place.
very good.
So let me just add, and maybe this is one of the things further down, Dr. Maxey, but one of the things that we can look at is just what color does the urine look like? People say, oh, well, there are all these old, well, don't eat the yellow snow. The urine is really, the urine is not supposed to be like deep yellow or almost tan. It's supposed to be closer to clear than it is to dark yellow. So I think there are things that we can do. We can keep pouring that water in the top so that when it comes out the bottom, it's looking more like water than yellow paint.
That's a really good point. Really good point. And I like your thing about don't eat the yellow snow. Very good. That neighbor Stephen takes next one.
What does ACR mean? Did I skip one? Did we do
Nope.
eGFR?
Yeah, we did.
Okay, what does eGFR mean? eGFR means estimated glomerular filtration rate. It estimates how well the kidneys are filtering waste from the blood. I would like to make a comment, a tail-on comment to what Dr. Walks was just discussing. If you start paying attention, if you haven't been paying attention before, to your urine, you will see that the color of the urine sometimes will correlate to things that you have eaten or things that you have either eaten or have drunk. So I was sort of a cautionary tale. I don't want to suggest that If you see a color change, that you immediately panic and think that your kidneys have shut down or something. But certainly, if you have any questions about the color of your urine, and I totally agree with what Dr. Walks was saying, that it should be closer to pale or clear, it's worth a follow-up question with your provider.
So let me add something to what you're saying. If you eat beets, you better not have red urine.
That would be a false statement.
What do you mean?
If you eat beets, you might see a pink tinge because of the pigment being excreted from the beets that you ate. You might also have red stool.
You shouldn't see red urine from beets. No.
Okay, so this is great. Here on Black Health Trust, we have almost disagreement. Now, that's why I don't eat beets. I ate beets once a long time ago, and my urine started getting a little bit pink, and I was very concerned about why my urine was. Now, maybe if I had drunk enough water, then it would. Anyway, yes, I don't eat beets to this day because it scared the heck out of me. So thank you for that, Dr. Neighbor Stevens. That, that
and beets are
we
good.
just we just have to be aware that our bodies respond to what we do, right? If
Yeah.
you don't drink any water and you're running around all day, you're going to have darker urine. And Dr. Lawson just came on, so Dr. Lawson can help with all of my anxiety. So there you go.
So what I'm trying to make, if anytime your urine is either dark, very dark or red,
Yeah.
you need to see and get it tested. Don't just say it's because I ate beets. That's
And don't say it if you haven't eaten beets.
right. Okay, let's go to the next slide. In fact, Dr. Lawson, since you just joined us, you want to pick up the next slide?
We got to get Dr. Lawson unmuted.
The next slide, oops, is this big thing here?
Number 5, Dr. Lawson.
Oh, what does ACR mean? Is that where you're at?
Yep.
Go to the next one.
Oh.
And number 6, why is protein in the urine so important? Protein in the urine may mean the kidney filter is injured. It also helps predict kidney disease progression and cardiovascular risk.
So let's discuss that. If your kidneys are leaking protein, that means you potentially are having protein links all over your body, in the brain, in the heart, liver, whatnot. It means that there's a lack of integrity of the membranes. So what's going on in the kidney is reflective of other tissues in your body. Anybody else want to comment?
I just think that is such an important statement, Dr. Maxey. When we think about all the things that could be going on in our body that we won't feel, that we oftentimes won't even know until something bad happens. So you just gave me something else to worry about. Now maybe protein is leaking in my brain. Look, the human body is an amazing construct. It just absolutely is. And if we think we can continue to just ignore it forever and wait till something breaks, we can't always fix the stuff after it breaks.
Very good. You want to take the next one, Dr. Neighbor Stevens?
What is the KDIGO heat map? The KDIGO heat map combines EGFR and ACR to classify kidney disease risk. Lower EGFR and higher ACR scores usually mean a higher risk.
So the KDIGO, we call it, is from the Kidney Disease Association, and they've developed what's called a heat map. And it's a map that has an x-axis and a y-axis, and where the values meet for protein in the urine and your EGFR predicts your possibility of risk of kidney disease, risk of cardiovascular disease. It's just a complicated heat map we use to define what your risks are and therefore what we need to do. We can go to the next one unless somebody wants to comment more on that particular question. Go ahead, Dr. Wilkes.
Number 8. If my EGFR is normal, can I still have kidney risk? And Dr. Maxey's answer is yes. Some people have normal or near normal EGFR, but still have kidney injury because the urine ACR is elevated. Okay.
So the way we look at something called CKD, if your numbers are abnormal for a 3-month period, it's called CKD. And your EGFR can be 90, can be 80, can be perfectly normal. But if you have protein leak in your urine, that's still considered a risk of further kidney disease. And that's very important. That protein is so important, even more so than the EGFR right away. Any comments on that one?
I think it's a really good point, right? Because as I was saying before, especially for people who don't have known risk factors, that urine testing may not necessarily be happening nearly as frequently. And I think a lot of times it is being picked up after the EGFR has changed, because with the exception of certain circumstances, we're not doing routine urinalysis, right? So it's a really good point that early kidney disease, that's the first place you're going to find it.
Also, if you play sports, sometimes you play football and get tackled and all that, ride a horse and whatnot, you may have a temporary amount of protein in the urine. So we want to make sure we do this on either quarterly or biannual basis. It may not just be one test that you do.
So,
Dr. Maxey, just want to know, as an ex-wrestler, it's also true. In many sports, they go high dehydration is done to help people make weight classes. And when they do that, a lot of these values come out grossly abnormal. And so again, deliberately dehydrating someone can produce some very awful findings in terms of some of these measures. And it is still done very often in wrestling and martial arts and football, boxing, and so on.
And the other thing you bring up, a lot of people are taking these weight loss drugs, and they can dehydrate you too. So it's important, if you're taking weight loss drugs, that you keep putting in at the top, as Dr. Walk says, be well hydrated, because they themselves can dehydrate you. They can lead to a decrease in EGFR and also increase kidney disease. So it's very important to stay hydrated, as we said. And we know that hydration requires at least 8 to 10 glasses or more per day in hydration, and at least 1,500 cc you lose just in insensible loss, not necessarily counting how much you may pee out. Let's go to the next slide.
Don't forget, we're in the summer and it's hot and muggy, and you can easily get yourself dehydrated if you don't keep up with your fluid intake.
Okay, who's next?
I think Dr. Hines.
Dr. Hines?
Dr. Hines is frozen.
Dr. Hines is frozen while we thaw her out. Okay, number 9. What blood pressure is considered high? The answer: blood pressure is considered elevated when it is consistently above the healthy range. Many patients with kidney disease, diabetes, or cardiovascular risk need a personalized blood pressure goal from their clinician. Oh.
Interesting. So here's maybe a little controversy here. Some of the guidelines say 130 over 80. The most recent guidelines I've seen say 120 over 80. Is it okay if your pressure is 135 over 80? Well, we know that pressure does not stay exactly the same all day. If you drink coffee, it's going to go up. Drink tea, it's going to go up. If you have emotional distress or input, is going to go up. Probably when Dr. Walls come out of church, it's up for a little bit. So it goes up and down. So an average of your blood pressure, I recommend a blood pressure target of 120/80. Let's comment on that.
Dr. Maxey, and I think it might be useful. We might want to have a whole session on that because a lot of people are encouraged now to take their own blood pressure. Plus, we now have situations in which we have paraprofessional health screenings at clinics and have blood pressures done. And sometimes these factors simply aren't taken into account at all. Some folks I've seen run around with, or in some clinics I've seen where you have a lot of patients who have elevated blood pressures, and it becomes, I would call it a clinic norm, that if your blood pressure is 180/90, gee, you're doing very good. You're better than everybody else in the clinic. So I think it might be useful to have a whole discussion on what is the meaning of blood pressure, especially if you do it one time and only one time in varying circumstances.
Good point. Dr. Hines, you on?
Yes, I'm back. I would completely agree with that because I think there are a number of people, to your point, walking around thinking they have white coat hypertension when what they really have is just regular old plain old hypertension, right? Because it's real. So to your point about the importance of checking your blood pressure at home, I know what I would tell my patients, especially for the ones who are reluctant to believe that that's really the thing. I will agree with them that this is just one moment in time, right? So go ahead and take your blood pressure a couple times. We'll talk about some different scenarios because that's your real life. This doctor's office isn't your real life. So then you can find out if you're, if you really have white coat hypertension or whatever, or if it was really the coffee, or if it was really the traffic, all those things. Because lots of people just don't want that to be their story.
So it's important to have a blood pressure cuff at home. And if you have a blood pressure cuff, you want it to be the kind that goes around your arm, not the wrist kind or the finger kind, but a good blood pressure cuff will be automatic. And speak a minute, Dr. Hines, about how blood pressure should be taken, not with legs crossed or.
So to your point, that your blood pressure should be taken with both feet flat on the ground, if you can, right? When you've sat down and you're able to be still, right? Take a few breaths, sit down, be still. So if you are also, I'll use my own life, fussing at my kid with my left hand while the blood pressure cuff is trying to take my pressure on my right arm, that might not be an accurate reading. So that is, and if you have on a sweater, or if it's winter, it shouldn't be over top of your sweatshirt or your big sweater. Take your arm out of that sleeve whenever you can. When you're taking your blood pressure, so again, that you get the right reading. And then also just being sure, blood pressure cuffs have a little line on them that show you whether or not that cuff fits your arm, right? And if the cuff doesn't fit your arm, and that could be because it's too big or because it's too small, both of those things can give you inaccurate readings.
Excellent. Very good.
Maxie, I just also note that on those of us who work with patients who are taking psychoactive medications, including recreational drugs, I had a patient who was stroked out because a juvenile who was a meth user. Many of these street drugs that considered, quotes, benign can either drive blood pressure up or drop it down low. And many of the antidepressant medications, especially some of the newer ones, really increase the risk. And now I see a lot of folks who are just mixing them together, who's taking especially medications used to treat attentional deficit disorder, where the blood pressure can really at one point look okay, but over the long term, it has some devastating consequences.
And comment on a couple of the street drugs that typically drive pressure up.
Yeah, and of course, almost all the stimulants will do that, as well as the common one, of course, is cocaine, which many folks feel is benign, seems to be benign, especially if it's part of a party or something else. And some of the newer, I call engineered street drugs, which can do it. Also, the narcotic opiate type agents can do just the opposite. The bottom can just drop right out of blood pressures. And some folks are going to a coma, right while you're talking to them.
And some of the medicines that you take for cold can elevate your blood pressure. So you want to make sure that you look at the effects of things that have epinephrine, ephedrine, and they may drive your pressure up.
Yeah, there's actually several agents that are used for dieting and for giving a more rapid response to antidepressants that are now being combined with standard antidepressants or diet medications. And these can shoot your blood pressure right up.
So,
Dr. Maxey, can I make 2 quick points?
of course.
The first is, not only do we want to take our blood pressures correctly, but we want to make sure anybody who's taking our blood pressures is taking it correctly.
Right.
And I'm not going to say any more than that, but that is a big a nerve for me. The other point I want to tag on to what Dr. Lawson just said. I can't tell you I can't, for HIPAA reasons, I can't really tell you too much about what I've been seeing in the population that I monitor. But my mind is blown at the number of young, and when I say young, under 40 individuals that have what's called non-ischemic cardiomyopathy, which means that their heart muscle is sick, but it isn't because they had a heart attack. It's because the combined effects of lifestyle plus the drugs, and their hearts just become an inefficient bag. There is no hope of cure. They can, if they clean up their life, they may be able to qualify for a heart transplant, but that's no picnic either.
Let's talk about, that's a very important point you make. We know that high blood pressure and the heart muscle pressing against that heart muscle to get the blood around your body is like weightlifting. And with lifting more weight, pressing against the higher blood pressure, it's going to build more thickness. And you're going to pick up heart enlargement. And at some point, that heart enlargement gets too much, then the heart will become baggy or floppy. And that's heart failure. So it's very important to make sure we have a more normal blood pressure. The other question I want to put to Dr. Neighbor-Stephens, we know that in an older person, say 50, 60 and older, the systolic or the top number of blood pressure is more important and indicative of what's going on in that patient with high blood pressure. In a younger patient, I'm told, and I like Dr. Neighbor-Stephens to comment on, it may be the diastolic pressure that is more important in judging hypertension. Can you comment on that, Dr. Stephens?
Well, specifically in individuals 18 and younger, any the systolic and or the diastolic are warning flags if they are not in the age appropriate range. And with what we're seeing now, there's some conditions that can end up creating high blood pressure. I'm thinking about nephrotic syndrome, which is something that's seen in kids. But with the epidemic of obesity that is going on in this country, I dare say the number one cause of high blood pressure readings in individuals under 18 is related to weight.
Good point.
Actually, also, now I'd like to follow through with that also, a colleague on Jules Ferrer Howard has done quite a bit of work of looking at people in chronic stress environments. And what we find is that many African Americans really do run chronic elevated blood pressures just because of coexisting anxiety and post-traumatic stress disorder. And so much so, in fact, that one meeting, a colleague of mine tried to tell me all those high blood pressure measures, those are white people's measures. Our measures should be considered adjusted for what we see in our environment. I told him that the body, unfortunately, doesn't recognize that kind of philosophy. But
Right.
but the point is that elevated blood pressure is elevated blood pressure.
So one of the things that I used to talk about in medical school was I had a formula for blood pressure. And blood pressure is equal to cardiac output times peripheral resistance. Peripheral resistance is a thickness or amount of constriction of your blood vessels. And cardiac output can be divided in two places: heart rate and actual stroke volume. So, and blood pressure is directly proportional to one of those three measurements. And we're told that Caucasians mostly have heart rate elevation as one of their main functions to elevate blood pressure, whereas people of color, it's the vascular stiffness, usually resulting from stress, from thickness of the arteries, etc. Let's comment on that in a minute, because I picked my drugs with that formula in mind. You want to talk about that, Dr. Hines, Dr. Lawson, Dr. Walks, any of us? And the reason I say that, one of the drugs that white people use a lot is beta blockers.
Right. Exactly.
And that slows the heart down. But with black people, we're interested in that constriction of blood vessels as one of the main reasons for elevated blood pressure. And that results from smoking, from caffeine, from cholesterol, a number of things. That total peripheral resistance is very important in that formula. Am I going?
So okay, so Dr. Maxey, I have a comment that at least in my brain is related to what you're saying. I've been watching some NBA basketball, and there's a guy named Hartenstein that plays for the Oklahoma City Thunder. I've been watching him play for several years, and I always thought he's just a really tall white guy. However, plus his name is Hartenstein, and he's from Germany. He got to be white, look white. Then I read an article about how his teammates treated him differently when they found out that his dad is black. And he talks to people about the fact that he's black. If y'all don't believe me, look it up. And we should have known the boy's name is Isaiah Hartenstein, the black white man that plays in the NBA. So when people start talking to me about what's best for black people and what's best for white people, the part of Black Health Trust that is for regular folks that don't have MDs and PhDs, we just need to make sure that everybody has a personalized primary care person that understands that even though your name is Hartenstein and you're from Germany, that you might be black and you don't look black. And that just because you're black, maybe beta blockers work better for you. I don't know. But Dr. Neighbor-Stevens made a point earlier about HIPAA guidelines and what have you. The reason those are in place is so people can have some confidentiality with their healthcare. And we just have to be willing to ask some other questions. The last part of this long point, I didn't think it was going to be this long, but I got to make this last part. When we talk about people based on how they look, many people come from different places, right? If I talk to one more regular brother that can't understand English because he ain't from here, right? People walk up to me, they want to talk to me, and I don't speak Amharic. I don't speak Spanish. They could be from Ethiopia or be from the Dominican Republic. So we have to, and when people come to this country, they may come here very healthy. And the next thing you know, they get introduced to McDonald's and Popeyes and suddenly they look like the rest of us that have been here for a long time. So I need us to be very careful that yes, there's a lot of science about what impacts historically Black people and Jewish people and everything else, while at the same time, none of that is an excuse for us not finding out the individual person's background, how long they've been in this country, what their normal diet is, and I can go on and on and on.
Thank you, Dr. Walsh. Go ahead and take the next question.
Since I'm already talking. No, I get riled up. I'm sorry. Okay, where were we now? On number 10.
Go ahead.
Why does high blood pressure damage the kidneys? Dr. Maxey's answer. High blood pressure puts excess force on the tiny kidney blood vessels. Over time, this can cause scarring, protein leakage, and loss of filtering function. I agree, Dr. Maxey. I think it's the same reason you talked about how the heart doesn't like high blood pressure. Our bodies are designed to have a certain amount of force that they're working with and working against. So you start forcing stuff through, it's like anything else. You put too much air in your tire and drive for a while and see how well the tire holds up with too much pressure.
Especially if it's hot and muggy. Dr. Hines, want to take the next one?
Sure. Why does kidney disease increase heart risk? And the answer is that damaged kidneys may worsen blood pressure, fluid balance, anemia, inflammation, mineral balance, and blood vessel health. And these changes can strain the heart and blood vessels.
Okay. Dr. Lawson?
What are warning signs of kidney disease?
Speak a little bit louder. Go ahead.
Excuse me?
Speak up a little bit, Dr. Lawson.
What are warning signs of kidney disease? Possible signs include foamy urine, swelling in the legs, fatigue, shortness of breath, poor appetite, nighttime urination, difficult to control blood pressure, or abnormal lab results. And I think this is a key thing. Many patients have no symptoms, none, early.
All right. Well, thank you. Let's go to Dr. Neighbor Stevens.
What are warning signs of heart attack or stroke? Well, the first thing is seek emergency help for chest pressure, severe shortness of breath, fainting, sudden weakness on one side, trouble speaking, sudden vision loss, or a severe new headache. But let me quickly add that women in particular don't have to have any of these characteristic signs and symptoms and could be in the process of a major either heart attack and sometimes even stroke. If, like I said at the beginning of this show, if you notice a change in the way your body is feeling, you need to follow it up, especially as you get further along in the years. But every now and then, we are saddened to hear in the news about some young person, 15 years old, dropping dead from a heart attack. So this is a serious question, and it deserves serious attention and hopefully integration into your memory bank, so that if some or all or anything that just isn't normal for you starts happening, don't just say, oh, it's heartburn. It could be, but it could not be.
And by heartburn, you mean what people call the indigestion, right?
Correct.
Let me follow with Dr. Neighbor Stevens' point. Not only perhaps women may present differently, but when women do complain, they're much more likely to be ignored when they make these complaints. Not only that, there's still many physicians who believe that Black people are immune to these kinds of problems. So when they complain, we're saying, well, you just not, you got to tough it out.
No, Dr. Lawson, they say they're drug seeking.
That's right. Good point.
Good
Yeah.
one. So in the past, Dr. Williams informed us that when he was a fellow in Boston, they told him black people did not have cardiovascular disease on the basis of arterial disease.
Right.
That we weren't capable of it. So you're right. That's been a problem. So it's not only women, it's black people in general often that get misidentified as not being eligible for a real heart attack. Let's go to the next one, Dr. Walks.
Hey, number 14. What are the biggest causes of kidney failure? Answer: diabetes and high blood pressure are the most common causes. Preventing and controlling these conditions is one of the best ways to protect the kidneys. So, Dr. Maxey, you're actually saying that we should use preventive health? We should proactively try to stay healthy? I don't know, Dr. Maxey.
Capital P.
That's some pretty innovative thinking right there.
There you go. That's
Is it me?
Now we can.
Oh, I thought it was me again. I could.
I lost Dr. Maxey.
All right, I'll go on and do the next one. If I have diabetes, why do I need kidney testing? And the answer is diabetes can injure the kidney filters over time, and regular EGFR and urine ACR testing can identify kidney damage early before symptoms begin. I think one of the things to remember in particular about why this is true, right, is because diabetes attacks damages the teeny little blood vessels, right? And as we've covered multiple times, there are teeny little blood vessels in your kidneys. And just like there are teeny little blood vessels in your eyes and teeny little blood vessels at the tips of your fingertips and at the tips of your toes. So that's what all of those things have in common, because those teeny little blood vessels are where diabetes and the inflammation that it causes starts to take effect. And obviously that's going to then impact all the things that we've been talking about today.
Dr. Hines, how do we know if we have diabetes or pre-diabetes? What's the best way to know about that? And
so
some of the thoughts?
The most commonly, especially in the pre-diabetes category, it's going to be that routine blood work, right? That routine blood work that sometimes might be a part of, work physicals or your annual physical or any of those ones where your blood sugar is supposed to be less than 100 if you went fasting. So you get that fasting blood work, and the answer should be less than 100. But if your number is 99 or 98, right, or in the high 90s, that is not a reason to go, whew, right? I am in the clear because it's less than 100. That also warrants further investigation, because as we're talking about, that could be indications that we are in the pre-diabetes category. And pre-diabetes doesn't mean pre-concerned, right? It means we just haven't gotten to diabetes, but there are absolutely things that you can do to see if you have diabetes. What usually happens next is you'll get what's called a hemoglobin A1C. And that is a number that checks to see how your blood sugar has been averaging over 3 months. And then if you're really being detailed, you can do a glucose tolerance test, which is basically you drink a sugary drink, and then after a period of time, they check your blood sugar to see if your blood sugar rises above a certain number. Because that's actually kind of like how we were talking about before with your kidneys, where that urine test is where the first signs show up. It's actually that postprandial or after eating blood sugar that goes awry first. So that's how you would know if you have diabetes.
Dr. Maxey, just want to know that I multiple times had experience with former athletes when they stop being athletic, i.e. a lot of guys after high school or college, go on a binge, and voila, discover that and there is a reported case of a professional boxer who, after he retired, blood sugar was 400. And his diabetes was diagnosed when his blood sugar was 400. And I've seen a number of high school athletes who then, when they get into college, don't exercise, don't run, and blood sugars end up 300s and so forth. They change their lifestyle. Of course, some of them often gain weight, but thought that they still had the protective effects of having regular exercise to keep them from getting ill.
So that brings up the point, and we ought to probably stop here. I know Dr. Neighbors-Stevens has a hard stop at 4. But maybe we just discuss about insulin resistance and what we can do to get rid of decreased diabetes and get in a healthy range of A1C. On that, any comments on how we can treat these numbers and what is insulin resistance and how can having a good muscle mass help decrease insulin resistance? And
Well, I'd
do
like to
that.
start by talking about what we can do to decrease insulin resistance in our kids, which is
Mhm.
a part of this whole obesity epidemic as well. And the American Academy of Pediatrics, this is actually not a new message, but we need to, first of all, look at lifestyle changes. What do I mean by lifestyle changes? Screen time 5 hours or more in a day in a kid over the age of 5. Under 5, they're not really even supposed to be having much screen time at all. They're not supposed to have any screen time until they're 2. But when we have the kids now over 5, if you ask them what they do all day and what they're watching, their screen time is 5 hours or more. What does that mean? It means that they have a sedentary lifestyle. And
Yeah.
then if you ask them what they're eating, you're going to find out that they have a diet that is high in processed, starchy foods, washed down with sugary beverages, whether we're talking about fruit juice or Gatorade or energy drinks, which they shouldn't be drinking. Any of them, all of them are sugary, which is adding to their caloric load, which is not being burned off, and I say that in air quotes, with activity. Often these kids are also not only eating a lot of foods that are not good for them, but they're eating a lot. They may not be eating at regular meals, but they're snacking all day long and getting up in the middle of the night snacking. So there needs to be a holistic approach to this, working with the family, adopting healthy lifestyle, increasing exercise to no less than an hour of moderate exercise a day. And then we should, if all of these methodologies are incorporated, we should see some improvement, because the good thing about kids, unless it's a girl over the age of 13 and she's had her menarche, or a boy who's over 18 and has completed his pubertal changes, they still got some growing room. But once you pass those, as I like to say, once things get locked down, then you got to start not incorporating that possibility of some growth. I'm sorry, I'm off on my stand now.
Thank you so much. Let's go around the track. We want to find out if we have any questions in the chat, and then let's do final comments if we would.
There are no questions in the chat.
Okay, Dr. Lawson, you want to start with final comments?
Yeah, I just want to follow through with what Dr. Neighbors-Stevens said. Everything she said also applied to the elderly as well. I still have a difficult time trying to convince people that not everybody who's elderly should be in a wheelchair. I was in the People's Republic of China and was impressed that they had elderly people playing around on the monkey bars. Very much a part of their culture. We need to do more to recognize that our elderly still need to exercise in order to maintain and to diet and not feed them fried chicken and ribs to help them to keep their weight up.
Even though you can't grow anymore,
That's right.
at least in height. Dr. Hines?
Well, I would just like to focus for just a moment on those not when you're not an adolescent, when you're not a kid anymore, like those 20 to 40-year-olds who may not necessarily have a PCP and not feel fine, so I don't even have a doctor, right? One of the things that I hope you would take away from this message is, if you're going to go, when you should be going to go get, some type of periodic checkup. And if you are, these are the types of things that you should be making sure that someone is doing for you, right? That someone is checking on, when you go. Doctors are people too. And even as we had in this conversation, varying opinions, doctors sometimes need to be reminded to check on some things or to answer some questions that you may have because you asked, you wanted to know, should I be checking my blood pressure, or should you sure you don't want to check my urine, or any of those kinds of things like we talked about today, so that then you don't end up being one of these stories we just talked about of young people who have unfortunate consequences.
Thank you very much. Dr. Walks?
I want to go back to, I think Dr. Neighbor-Stevens talked about some cultural changes we need. We need to stop looking at people and saying, I don't want to body shame you. I want you to feel great about yourself just the way you are. If I see one more young person walking around with their belly outside, and their belly is not something that they should be carrying around, they need to be more fit. They need to be out moving around, because people believe that once the doctor tells me what's wrong with me and they give me a pill, I'm good. I got news for you. Those medicines work best, and maybe they don't work at all if you don't exercise, if you don't move your body around. So, I like to try to act like I'm young and say, miss me with the I ain't body shaming. I'm not going to body shame you, the individual person, but I think as a culture, we need to stop saying it's okay for us to be, what they used to say, Dr. Maxey, big boned. No, no, you're not big bone. No, you are, as Dr. Neighbor-Stevens said earlier, we have a lot of children who are obese and think that they are just looking great because the culture is saying, it's okay. I'm going to put that little short top on and people better not say a word because they don't want me body shaming me. Don't walk past me.
Thank you.
Catch me on a bad day.
All right. Thank you, Dr. Walks. As my final word, I'm saying I appreciate everybody's help in going through these questions. I think these are some of the things that people have been asking, and maybe we'll continue these at another point. Have a happy Sunday, everyone. And thank you to Dr. Hines, Dr. Lawson, Dr. Walsh, and Dr. Neighbor-Stevens. Have a great Sunday. Thank you very much, Simon. Have a good day.
Good day,
Bye.
everyone.